Welcome to the Vet Dental Show. I'm Brett Beckman. I'm a board certified veterinary dentist, and we come to you every week on Wednesday to provide the veterinarian and the technician team some actionable things that you can use in your practice. And this episode is going to be a recorded episode that we've done in the past, not a podcast that we've recorded or not the Vet Dental Show, but actually some other information for you that we know you're going to enjoy. So sit back, enjoy, and we'll see you at the end of the podcast.
Kara Patrick asks, in dogs where that first mandibular molar is resorbed in the middle of the root, apex has intact periodontal ligament. Do you go after that tip as well, or would you expect it to resorb eventually?
That's a really good question, and that's hard, really hard to answer. It depends on the stage. If we were to look at that first molar as it exists there in that x-ray that I showed you, if you had all that resorption and you had a little area of lucency around the root tip, we would not go after that. We would monitor that. And the reason is all of that structure there that's been resorbed is generally idiopathic resorption. There's no infectious process that's involved with that. The pulp cavity is obliterated and there's no pulp from apical to mid-root there. So for that to be pathology is very unlikely. Good question.
Here's a really good question regarding positioning. Do you recommend ventral/dorsal versus lateral for radiographs?
Well, you're the expert. Why don't you take that one?
Absolutely. And I teach radiographs to many people all across the country. And I've taught technicians as well as veterinarians that have taken them, have been taught in lateral recumbency and have been taught in ventral dorsal. We teach in ventral dorsal just because the learning curve is much less than lateral. Now, when I tell my students, if you're taking radiographs in lateral and you can do a small dog and a cat in less than 5 minutes, getting diagnostic views without frustration, without hangups, don't change what you're doing. But for people that are just learning or people that are struggling with lateral, ventral dorsal is absolutely a game changer and will help to not only position that sensor and tube head a little bit easier, but troubleshooting, which is about 80% of taking dental radiographs. I don't take a perfect shot every single time. I can get a diagnostic view in 1 or 2 shots. Every once in a while, maybe 3 shots, but typically 1 to 2 shots. Troubleshooting is the key. And troubleshooting in dorsal ventral is much easier than in lateral. So from a firsthand experience in teaching folks and their feedback, it's always been, oh my God, this is so much easier. I was taught with the bisecting angle and the sticks and the protractor and in lateral, and this is way, way easier. I can picture what I need to do and working off that horizon as opposed to turning your world sideways and working in a lateral aspect. Ventral dorsal is much easier.
Yeah, and maybe to further clarify that, when you induce the patient, they're already in dorsal recumbency. So you take the whole maxilla after you intubate, turn the patient over, you take the whole mandible, and you only turn them one time. It makes it super easy. And that book tells you what angles to take that on. And it shows you where to put your sensor in the mouth. So you put together what Annie said, that brief little thing that I just said, and take those 2 resources, that's going to get you where you need to go.
Okay, Justin Sancho asks, why is imaging PM4 in a large dog much harder than a small dog? Any recommendations?
You got a bigger target on a small sensor, number one. So you're trying to fit that big tooth onto that size 2 sensor, which makes it a little more challenging.
All right, here's a very common question that we get from Linda Duggar. Do you clean the teeth before radiographs?
The recommended protocol from induction to recovery is after reduction, you take full mouth radiographs. And then in my case, Annie reviews all those before I even see them. So she's got the chart filled out within minutes, and she's got X's through all of the teeth that we're going to extract. And what that tells her is what teeth not to clean while I'm reviewing the radiographs and we're discussing the estimate. So those teeth that have calculus, that are going to be extracted, you do not waste the patient anesthesia time cleaning those. There's absolutely no reason to do that. You are going to, in all cases, do surgical extraction. So you're going to open up all that. You're going to clean all that tissue out, that soft tissue that I mentioned on that vertical defect. That's going to be all through all of that submarginal bone that you've exposed when you're extracting these teeth. And so we're cleaning everything out where it means something. We don't care if there's calculus on an inanimate object, which is the crown. We don't care about that. We're gonna remove that tooth, so there's no reason to clean it. There's also no reason to chart it. You don't have to stop and do probing depths all around that tooth and mark your probing depths and take the time to do that. You can very quickly and easily put PD2, PD3, PD4, depending on 25%, 50%, or greater than 50% bone loss. And that's your justification on your dental chart to extract those teeth. You're not going to come back and check pocket depths because those teeth are going to be gone. It's going to be healed, attached gingiva where those teeth were. So there's absolutely no reason to chart them other than the periodontal disease parameter, and there's no reason to clean them. So that has been and that's a great question. I'm passionate about this because this is something that people do, even at the specialty level, they're doing this. And it's just a waste of anesthesia time, a waste of technician time, and just not something that we need to be doing. And I don't mean this as a rant on the person that asked this question. I'm just relaying how important it is not to do that.
And it doesn't matter, even the thickest calculus, we're looking at the velar bone to the apex. It's not going to occlude where you're seeing pathology. The calculus isn't going to show up or block anything that you're not going to be able to see on an x-ray. So even the dogs with the thickest calculus, there's no reason to remove that because it's not going to be in the way on the x-ray. You're still going to be able to see the pathology that you need to see. So not before radiographs and certainly not before extractions. We're not cleaning teeth. Absolutely. Okay.
Thanks for clarifying that, Annie.
Yeah. David Delaney asked, is it reasonable in general practice to stage a mouth in one anesthetic episode, then do an extraction episode with a better estimate?
David, yeah, that's a great question. It's great for everybody to hear the answer to that. We don't do that. And the reason we don't is at the specialty levels, we have people coming from different states, different countries. And so they want to have that procedure done that day. So we have a really good idea how many cases we can do each day, depending on whether the perio, fractures and potential root canals, jaw removals, whatever it might be for cancer. We have an idea about how long it takes us to do all that stuff. So we get that number of patients in the morning. We see them from 8:30 to 10:30, and then we do cases after that. And we stay until we're done. In general practice, if you're doing dentistry at a pretty high level and you're doing surgical extraction and you're doing them well, you might be able to do 3 cases a day because you're looking at small dogs mostly, and most of those dogs have 8, 10 full mouth extractions, and a lot of the time those are 2 to 3 hour procedures. So if you do 3 of them and they're 3 hours each, that's 9 hours. And that doesn't account for the turnover time between patients. So two cases of these big cases a day is not unheard of in general practice at the level where you're comfortable doing multiple extractions correctly with given a 2 to 3 hour window. So I would say that 2 hours would be probably the low end. You're probably looking at more like 2.5 on the average, if not 3, especially if you're in a good intermediate stage and you're comfortable doing extractions, but you're not super quick. That's where I would find the sweet spot. That being said, what that protocol that you mentioned, where you come in, you get the radiographs, you do the probing, you do the cleaning, and you stage those, and bring them back in a month or whatever the time frame is, where you can schedule them, what you're going to be getting into ahead of time. You got a really good idea about how long it's going to take you based on your experience. And so you eliminate having the other duties disrupted that you might have, like afternoon appointments, and you're not in a hurry. And the staff is so much more relaxed. Everybody's stress-free. You're not trying to hurry through everything. And it just makes everything much better in general practice. So that is a super good technique and works really well in general practice. And we have multiple of our veterinary dental practitioners who are top-notch. They're the best in general practice in the world, and a lot of them are doing that. So it's perfectly acceptable to take that approach, and I would recommend it, especially when you're first starting.
Okay, Kathy Connolly asks, with resorption in cats, my understanding is that we need to remove all of the teeth affected completely, or the small pieces of teeth remaining will keep causing inflammation in the oral cavity. And then she has in parentheses stomatitis cats.
Yeah, stomatitis is an exception. Everything needs to be removed in stomatitis cats, even the resorption. So I give the example of how we approach tooth resorption in a mandible in a cat, where you've got tooth resorption. You may not have a crown, but you've got tooth resorption there. Just given the pathophysiology of which we don't understand really well, but we do know that if there's root structure left after we do extractions, that's going to perpetuate refractory stomatitis. So in stomatitis cases, I will go in and I'll do literally a dugout canoe effect in the mandible, and you guys do not want to do this, but this is a referral, and I'll further qualify that. If you're not doing cat full mouth extractions in 2.5 hours or less, do not even think about doing a stomatitis case. They require a lot of time. They require somebody that's got a lot of efficiency and skill. And so and on top of that, some of those don't resolve. And so those are lifelong management for refractory cases that require specialist knowledge to be up to date with all that stuff and be able to talk to the owners confidently and guide them through that, even from the first exam, that, hey, maybe this cat's in that 20% that's going to be refractory, and here's what to expect. Got off on a little tangent there, but it's super important to realize that. But essentially, these are specialist or very advanced practitioner procedures. Our veterinary dental practitioners that have been through our year-long course, they are doing these and doing them confidently and very well. But if you don't have all that experience, please do not try to do these. It's going to be like fracturing a mandible. It's going to be very frustrating. You're not going to be confident going in. It's very stressful, knowing that you got to get everything out of there. That being said, if you're extracting a tooth in a non-stomatitis cat, and there's no tooth resorption, you need to get all those tooth roots out of there. So I hope that spanned the scope of that question and I answered it.
I hope you enjoyed this episode. There's a lot of actionable items in there that you can take and use in your practice immediately. So put those to work and enjoy the benefits for the practice lifetime in your dentistry service. So until next week, have a great week. Take care, guys.